Let's talk about innovative hemodynamics. First of all, these are my conflicts of interest. As said by Niels, I'm chair of the cardiovascular dynamics section of the ESICM, but I'm also chair of the subcommittee 14, which is on monitoring from the European Society of Anesthesiology. So this is why I cover some hemodynamic topics at this conference maybe. And the topics I want to discuss with you in the following minutes are these three ones: dynamic arterial elastance, mean systemic filling pressure, and hypotension prediction indicator. Let's start with the dynamic arterial elastance. Is any one of you familiar with this variable concept? No one? So it's worth talking about it. So let's start. What is the definition? So elastance in general is a measure of a tendency of a vessel or organ to recoil toward its original dimension upon removal of the distending or compressing force. And if you want to express this mathematically, it's the quotient of pressure difference and volume difference. And this is just the reciprocal of compliance. Compliance you might be familiar with, so elastance is just the other way around. And arterial elastance is a measure of arterial wall stiffness, or arterial load, if you will, and it's the expression of the total afterload imposed to the left ventricle of the heart. And it's determined by the total arterial compliance, impedance, and the systolic and diastolic time intervals, and the capability of the arterial vessels to increase pressure, mostly in hypotensive patients, when the left ventricular stroke volume increases. Sounds complicated, but it's not. If you want to read more about this, this is a nice review article summarizing this. So actually, it's you measure blood pressure, you might measure blood flow, and the arterial elastance is just a connection between those, giving you information about arterial load. And this is a very old principle. This is Otto Frank, a German physiologist who already described this Windkessel function, which is a German word. It's describing the elasticity of the aorta when the heart ejects its stroke volume. And this is also found here. For example, this is a fireworker, and the pump is delivering a pulsatile flow, and this Windkessel, as it is called, is making sure that the flow through this hose is continuous, so they turning and the elastance turns the continuous the pulsatile flow as created by the heart to a continuous flow, as we also see in the microcirculation. All right, so we have a two Windkessel model, a pulsatile component, which is the net arterial compliance, and a resistive element, which determines your total vascular resistance. So the arterial elastance is an integrative parameter of arterial load that incorporates both the pulsatile and the steady components. And it represents changing in arterial pressure in response to the stroke volume of the left ventricle, as I said. And you can, the cardiologist, calculate this by these pressure volume loops as the ratio between end systolic pressure and the stroke volume, and you can calculate the end systolic pressure like this. It's 90% of the systolic arterial pressure. If you don't want to measure it in the left ventricular chamber, you can estimate it like this, and this way you can calculate it. The other thing we have is the dynamic arterial elastance, and this is what we talk about in more detail in the following minutes. So this is a functional measure of arterial wall stiffness, and it's mainly determined by the central elastic compartment, so the big arteries, if you will. And it's obtained by the ratio of pulse pressure variation and stroke volume variation. Pulse pressure variation is just a pressure-based variable, and stroke volume variation is a volume or flow-based variable, as you will. And this is the way how to measure it. So this is just a flow signal from the arterial pressure curve, a pressure signal, and this is a flow signal obtained by a esophageal Doppler. And if you analyze these signals within one ventilatory cycle, you can calculate the dynamic arterial elastance. Which questions can this variable answer you? So you can answer the questions: can this dynamic arterial elastance predict fluid responsiveness in hypotensive patients. So if you give fluids to a hypotensive patient, will the pressure actually increase or not? And if a patient is fluid responsive, will arterial pressure improve with volume resuscitation? This is what you want to know. This is why you would give fluid. And if you know this beforehand, it would be nice. So the considerations are, if the arterial dynamic elastance is high and the patient is preload dependent, arterial pressure will increase along with cardiac output after volume expansion. So you give volume, this increases flow, and this ultimately will increase blood pressure. This is the sequence. And the greater the dynamic elastance, the greater the improvement in arterial pressure will be after such a volume expansion. All right, so Michael Pinsky is an expert on this, and he summarized this in this review article. Dynamic arterial elastance is a surrogate of cardiac afterload, as I told you, able to differentiate arterial vasodilation from hypovolemia as a cause of hypotension. So this is also a very important information to know what is causing your hypotension. He further said, if the arterial circuit becomes stiffer, then for the same stroke volume change, arterial pulse pressure will change more and the other way around. So this is also very natural. And if the arterial compliance decreased, for example, as if you give a vasopressor, then the PPV-SVV ratio or the arterial dynamic elastance will increase. And finally, when you vasodilate a patient, then this ratio will finally decrease. And this is a pulse pressure curve, which is curvilinear. And here you see for the same stroke volume variation, if you're on this part on this curve, for the same stroke volume variation of 18%, the pulse pressure variation is also 18% at this part. But if you go at this stiffer part, let's say, then for the same stroke volume variation, now you get a pulse pressure variation of 27%. So the ratio of these two variables is increased to 1.5 from 1 in this case, just for the same increase, same stroke volume variation. This is, again, the effect of vasodilators and vasoconstrictors. So this is a normal arterial elastance. And if you give a vasodilator like nitroglycerin, you will decrease this variable. And if you give a vasopressor like methoxamine, which is a pure alpha constrictor, you will increase this elastance. And this has also been shown for vasodilators by the group of Michael Pinsky again in patients after cardiac surgery. And they give a vasodilator, and this significantly increased both pulse pressure variation and stroke volume variation, what you would expect from a vasodilator, but the increase in stroke volume variation was greater than the increase in pulse pressure variation, so the ratio of these two variables, the dynamic elastance, decreased, as you can see here from these calculated numbers. We did studies in patients after hepatic resection, which were on vasopressors, and wanted to see if, by calculating this ratio of PPV and SVV, if we could predict the volume, the answer, if we could reduce the norepinephrine in our patients. And actually we found that this dynamic arterial elastance was significantly correlated with the norepinephrine requirement. So the more norepinephrine we needed, the higher was the dynamic elastance. This was also what we expected. And it was inversely correlated with the difference in norepinephrine requirement before and after fluid resuscitation. So if we give fluids to our patients, we could decrease the norepinephrine requirement, and we could predict this quite nicely, as you could see here from this receiver operating curve. And this is also confirmed by a French group here, which did this pretty much the same thing in patients with septic shock. Also, they could decrease the norepinephrine dose and could predict this by the decrease in this arterial dynamic elastance. The next topic I would like to spend some time discussion with you is the mean systemic filling pressure. Does anyone have experience with that variable? Also not. You have. Very good. So what is the mean systemic filling pressure? You can just imagine if you stop your circulation, all the pressures in the body, arterial pressure, central venous pressure, will equilibrate because there's no more flow. And this pressure which you measure at that point would be the mean systemic filling pressure. And this is a pressure that determines how much is the circulatory system, or how much are the vessels filled with fluids, right? Actually, it's not very useful to stop the circulation in patients. They don't like it, and we don't do it on a regular basis, so we have to find another way to measure it, and we will come to that in a minute. But this is the principle. So this is we have two reservoirs here, a big one and a smaller one. This is the venous compartment, this is the arterial compartment, and there's a guy sitting here with a bucket and putting water from this part to that part. This guy is the heart, obviously. So this guy is pushing this stroke volume here into this reservoir meaning the diastolic or the venous compartment, where you can measure mean systemic filling pressure, or an analog of this. We can come to this in a minute. There's a connection between these two basins, and this is the resistance to flow, and this is the central venous pressure, if you will, and the heart, or this guy, keeps this central venous pressure low by putting the water back to this reservoir. This is the way how it works, and this is a stroke volume or cardiac output over time. And you can also measure the function of this heart by this calculation of measuring rate atrial pressure and mean systemic filling pressure, the driving pressure for the circulation. Actually, there was a monitor which did these calculations for you. It was called the Navigator. It has disappeared from the market 2 years ago, I think. It's a pity because it was very useful, but it's no longer available, as I said. Okay, coming back to our study. So our patients received fluid bolus, and we calculated these mean systemic filling pressures according to this Parkin formula, which I show you in the next slide. We also calculated the pressure for venous return, the driving pressure for venous return, which is the difference between the mean arterial systemic filling pressure and the central venous pressure. And we also calculated the resistance to venous return and this heart performance, which I just showed you in the previous slide. And this is a formula if you don't want to put your patients to cardiac arrest to measure the systemic filling pressure, which we did not prefer. You can calculate it, and this is the formula how to calculate it. It's actually based on the venous arterial pressure difference and based on some assumptions on arterial and venous compliance, which are given here. So these are the results of our studies. Let's first look at mean systemic filling pressure. You see at the beginning, mean systemic filling pressure was the same in the responders and non-responders. So when we give fluid, we can say these are responders, which increase their cardiac output after the fluid, and we have non-responders. We had 18 responders, 12 non-responders, and the mean systemic filling pressure per se could not differentiate. So it was the same in responders and non-responders. Just saying that static pressures like CVP and PCVP are not useful in predicting fluid responsiveness. After the fluid intervention, in both groups, the mean systemic filling pressure increased. Of course, if you put volume into a system, the mean systemic filling pressure, the filling pressure of the system should increase, and this happened in both groups. Now let's look at the pressure for venous return. So the difference between the mean systemic filling pressure and central venous pressure, which is the driving pressure for the heart to increase cardiac output. This was lower in the responders. These are small numbers, small differences, but we are talking about low pressures. So this was significant, lower in the responders at baseline. And after the fluid challenge, it did not change in the non-responders, but it increased in the responders. And this increase led to the cardiac output increase, which you can see here. So in the responders, the cardiac index increased due to this increase in the pressure for venous return, and this is, of course, why they are defined as the responders. This is another study from a Swedish group, I think. They did pretty much the same thing. Here you can see the Frank-Starling curve, and you see superimposed the venous return curve. And if you give fluid, they gave fluid to their patients. And you can see here, if the mean systemic filling pressure increased more than the pressure difference in the right atrium, so this is central venous pressure, then you are in this part of the Frank-Starling curve and cardiac output increased. If, however, the increase in the difference between mean systemic filling pressure and central venous pressure increased in the same way, then cardiac index did not increase, as you can see here. Then you are on this part of the Frank-Starling curve. So this is a way how to apply mean systemic filling pressure to predict fluid responsiveness. The last thing I would like to discuss is the performance of the heart. The performance of the heart was equally in non-responders and responders in our study, but after fluid responsiveness, it decreased in the non-responders while it maintained the same in the responders. And this is clearly indicating that the non-responders could not handle this fluid which we offered them. The heart of these patients deteriorated after this fluid challenge. So it's not only useless to give more fluids if they don't need it, it's even deleterious. It decreases the function of the heart. And this is to show how you could use this pressure for venous return to predict fluid responsiveness in comparison with the classical dynamic variables, stroke volume variation and pulse pressure variation, which performed quite well. It even compared to those compared equally good to predict fluid responsiveness. And this is a final slide to show you a correlation nicely between the increase in cardiac index and the increase in the pressure for venous return, because the pressure for venous return determines venous return, which is the same as cardiac output, of course. What comes in the right ventricle must go out from the left ventricle, right? So, and this is a nice correlation, as you can see, and these are the responders and these are the non-responders, but they all fit very much, very nicely on this line. And we have another study going on with colleagues here in Belgium, in Gent, where we looked in preload-dependent patients and give them phenylephrine, and we can see that with if you give phenylephrine, which is a vasoconstrictor, also on the venous side, you can increase this mean systemic filling pressure, and this would increase to also lead to an increase in this pressure for venous return, which then would, as you would expect, lead to an increase in cardiac index. As you can see, this is the blood pressure, and the blue one is the increase in cardiac output. So phenylephrine, not sometimes in some patients, in normal patients, would decrease cardiac output, but in preload-dependent patients, by this mechanism, it can increase cardiac output by increasing venous return. The last minutes I would spend on a new variable, which is called the hypertension prediction indicator. Anyone heard about that one? No? So I'm telling you really something new. Very good. So what is it? Predicting hypertension is important. Why? Okay, if you have a hypertensive event, then it can cause complications. There's no discussion about this. It can cause renal failure, it can cause myocardial injury, and even increase mortality. And if such an event occurs, it takes some time until you start your treatment. You have to take some fluids or prepare some norepinephrine infusion or something. So, and the damage is accumulating here. So it would be very nice if we could predict such an event before it actually occurs, right? So this is why what I'm talking to you right now. And this is also based on complex cardiovascular physiology. So normally you have a variability in heart rate. As you sit there, you have a heart rate variability, which is quite normal. So the distance between two successive heartbeats is different, slightly different from time to time. And this variability you can measure, which is good, which is a reflection of the organism to adapt to changes. And you have a complex arterial waveform. But if you go into shock, this complexity decreases and also this variability decreases. And the third aspect, which is used in this prediction of hypotension is associations between different variables which all are interrelated. So this is complex mathematics, and this is just showing again the variability of heart rate, which is great or large in normal patients, but if these patients get hypotensive, this variability decreases, as you can see here in the fast Fourier transformation information. And there's a new in the monitor you can calculate or predict hypotension using signals of the dynamic interactions between these physiologic variables I just showed you, which you cannot see with the human eye. But just looking at the monitor, you will not see it. So you need some machine techniques to help you with this. How it actually works is like this. You take you look at the arterial pressure waveform signal, which you can derive from either from the arterial line using a flow track, or not even non-invasively by using such a finger cuff. And then you take this pressure signal and predict the hypotension from it. How does it work? It looks very closely at this arterial pressure waveform, which contains a lot of information, as I told you yesterday already. So you can get a lot of information from the morphology of this waveform about the elastance and the amplitudes and the slopes and the variability and the entropy of the signal. And by doing this, it can calculate this hypotension probability. So the probability that a hypotension will occur, and hypotension is defined as a mean arterial pressure below 65. I cannot go back, but anyway. So this is how it works. If the hypotension probability is low, it gives you a low value, which is displayed in green, and if it gets red, there's a high probability, a 97% probability that a hypotension will occur. So these are data from patients in the OR, and you can see if this hypotension probability index is low, the actually event rate is also low, and it takes also a long time until hypotension actually occurs. But the greater this hypotension probability index gets, the higher the actually hypotension occurring will be, and the shorter the time will be until this hypotension will actually occur. And these are data from ICU patients. ICU patients are a little bit more stable than OR patients in general, so the time until this hypotension occurs are a little bit longer, but it works in the same way with the same efficiency. So the higher the probability index tells you, the higher the event rate and the shorter the time to the event being the occurrence of hypotension below 65. And this variable can be configured on your monitor. It can be configured as a trending variable as your blood pressure or stroke volume variation. You can see here the HPI variable. And if this probability indicator exceeds a certain range, 85% probability, a secondary screen pops up like this, and you can ask for more information. And if you do so, such a screen comes up which gives you more information about the potential cause of the hypotension and also how to treat it. This is the secondary screen I just enlarged for you, and this gives you information about your preload. So based on stroke volume variation, you can get information about the preload, and if the preload is low, you might consider volume intervention. It also looks at the upstroke of the curve. So this is gives you information about the contractility, and you might consider giving an inotrope if this is low. Or it looks at this arterial elastic dynamic elastance, which I spoke about in the first part of my talk, which gives you something information about the resistance of the arterial load. And if this one is low, you might consider giving a vasopressor. By the way, you can get all this information or even non-invasively with the modern technical devices, so you don't have to put invasive catheters in your patient if you want to use this for predicting hypotension. Okay, these are data from our hospital. We looked at 74 patients so far, typical population. In 72 out of these 74 patients, we saw hypotensive events, defined as a blood pressure below 65. So even, and these were all patients that were in goal-directed therapy studies and so on. So even if these patients were taken care of very good, as we thought with our protocols, we saw almost in every patient hypotension. The number of hypotensive events in these 74 patients were 706, which makes 10 hypotensive events per patient. And if you accumulate these times, it was 47 minutes of the operation that this patient spent in hypotension. And if you calculate this to the average time of the operation, it's almost 20% of the time the patient spent in hypotension. And this is the predictive ability of this new hypotensive prediction indicator to actually predict this hypotension. So the pink one is the curve at the occurrence of hypotension. Of course, this is ideal. This is a 100% specificity and sensitivity at the moment that the hypotension actually occurs. The green one is 5 minutes before the hypotension occurs. So you can see still with excellent sensitivity and specificity, you can predict the hypotension 5 minutes, and this is the blue one, is even 10 minutes before the hypotensive event occurs. You see here even also a very good predictive ability. Some of you might say, okay, by looking at the blood pressure, I can see, I don't need this. I see if the blood pressure goes down that the hypotension will occur. Is that true? Yes, it might be true. So we looked at the same, we compared this predictive ability with the changes in blood pressure. And we looked at the changes in blood pressure also at the moment of the events, 5 minutes before the events, and 10 minutes before the hypotension actually occurs. And these are the curves, the receiver operating curve. So this is at the moment that the hypotension occurs, 3 minutes before the mean arterial pressure could not predict it. This is 5 minutes and 10 minutes. So this is just like flipping the coin. So no, but just by looking at the changes in mean arterial pressure, you cannot predict hypotension as good as with this new variable. And we compared it also with other variables that you might think of useful, like cardiac output, stroke volume, the dynamic variables, and all of them don't perform as good as the hypotension prediction index as shown in this ROC analysis curve. You can choose here the one that you like to use in your daily practice, but all of them are much less than this hypotensive prediction indicator. And this is just all of the data points from our patients, the relation between HPI and mean arterial pressure. So at the same mean arterial pressure, you can have a low or a high probability. So it's not simply a mirror or a reflection of mean arterial pressure. And the dynamic, and this is the event rate again, showing that the higher the HPI tells you, the higher is the actual occurrence of hypotensive events. And these are the dynamics. So if you get, this is the occurrence of the hypotensive event. If you go back in time, you can see that the changes in this HPI variable are much more dynamic than these changes in mean arterial pressure. So prior to hypertension, the change is more obvious of this variable. And I end with two cases. This is a patient during surgery. This is a major abdominal case. And here you can see the HPI indicator, which is going up here. This is above 85%. And then it takes another 8 minutes before the hypotension actually occurs. And the anesthetist was blinded to this measurement, and it takes another 7 minutes before the hypertension is treated. And this is another case, a kidney transplantation, and here it takes, again, the prediction was only 3 minutes, and it took, in this case, 15 minutes to correct this hypotension by volume infusion. So if you can prevent this time, you might have some benefit for your patients. With that, I come to my conclusions. So in my first part of my talk, I told you that the dynamic arterial elastance can be used to assess vascular tone at the bedside, and with that, the need for fluid or vasopressor therapy, important differential diagnostic. In the second part, I told you that the mean systemic filling pressure can be used to track fluid-induced changes in volume, and it can also predict fluid responsiveness as good as PPV and SVV. I told you that this measure of cardiac performance can be calculated from that. And in the last part of my talk, I told you that this new hypotension probability indicator predicts hypotension reliably up to 5, or I should say 10 minutes before it actually occurs, which buys you time to take interactive measures. It predicts hypotension better than changes in mean arterial pressure or any other variable we have so far does. So it buys you time to measure before, to take measures before the hypotension actually occurs. But of course, this is the very beginning. We need more data to evaluate if this will change the way we treat our patients and if it has an effect on patient outcome. Thank you very much.